I think we should go ahead and get started, and we'll
Okay.
just leave it
Okay,
as.
you tell me when to start. I do the housekeeping also, yes?
Yes. So
Okay.
I'll go ahead and click start webinar and then record. Ida, are you ready to begin?
Yes.
Okay.
Hi, everybody. Thank you for joining EGPAF for the Evidence to Action webinar series. This series is Saving Lives of Mothers, Journey to Eliminating Cervical Cancer. We're very excited with this opportunity. Next. Before we start the session, I would like to put the housekeeping. Interpretation will be available in Portuguese. To use the interpretation feature, you have to use in your webinar control at the bottom of your screen, click interpretation, and then click the language that you'd like to hear. Again, this is Portuguese. And then to hear the interpreted language, click mute original audio, and you can see the guidance here. Please introduce yourself using the chat feature at the bottom of your screen. And please submit your questions and comments using the question and answer feature at the bottom of your screen. This E2A is being streamed live and recorded, and EGPAF will share the recording at the conclusion of the webinar. So the agenda for today's session is, I'll start with a very brief welcoming remark, an opening remark, and our panelists will be presenting their slides. The panelists, I will introduce the panelists later on, and then as we finish the session, we will have a question and answer session. Our panelists are from Kenya, Lesotho, and Tanzania. So during Cervical Cancer Awareness Month, in January 2023, the Elizabeth Glaser Pediatric Foundation joins the global conversation on raising awareness about cervical cancer and human papillomavirus vaccination. Cervical cancer is one of the leading cancer among women globally. In low and middle income countries, account for 90% of death resulting from cervical cancer. Women living with HIV in particular are very vulnerable for cervical cancer. And globally, as we all know, the strategy has been developed for elimination of cervical cancer. With the aim of eliminating cervical cancer, all countries must maintain an incidence rate of below 4 out of 100,000 women. So under the strategy, we have vaccination to cover 90% of girls fully vaccinated by age of 15, screening 70% of women screened using high-performance tests by age of 35, and again by age of 45. Treatment, 90% of women with pre-cancer treated and 90% of women with invasive cancer managed. Each country should meet 90, 70, and 90 target by 2030. So this E2A will include panelists, Irene Alaska Wattoyi, Senior Technical Officer, Care and Treatment for EGPAF Kenya, Dr. Oluwasanmi Akintade. He's the Director for Sexual Reproductive Health Lesotho in EGPAF Lesotho, Angasyege Kibona, Senior Technical Advisor, Reproductive Health, EGPAF Tanzania. These are among our experts in cervical cancer and reproductive health. And in this webinar, we'll share insights on new frontiers and assessments, screening, identification, and treatment of cervical cancer. Irene will be focusing on early identification and treatment. Dr. Akin will be focusing on tiding the gap in treatment, and Kibona will be focusing on quality assurance, but mainly on digital solutions. Next slide. I'll hand it over to Irene. Irene.
Okay. Thanks a lot, Ida, for the opportunity. I'm Irene Alaska Wattoyi, Senior Technical Officer working for Vocation 95 project in Homa Bay County. So Vocation 95 project started in September 2021 and should be ending in It started in October 2021, and it should be ending in September 2026. It is in 2 counties, that is Kisii and Homa Bay. So for this presentation, I'll be presenting on behalf of Kenya on Rapid Result Initiative that helped us to improve on screening and identification as far as cervical cancer is concerned. Next slide. So that is the outline of my presentation. Next slide. So why am I talking about Timiza 90? This is because the initiative was implemented during Timiza 90 project, which was a 5-year project that started in October 2016 and ended in September 2021. It was in Homa Bay County, supporting 164 sites. It was funded by PEPFAR through CDC. And as you can see in the photo is our country director on the right with other key stakeholders during Timiza 90 project. Next. Next slide. So our main aim of the initiative was increasing the number of women of reproductive age, our target being 25 to 49 years, living with HIV, screened for cervical cancer in Homa Bay. And we implemented the RRI from the month of June to August. It was a 3-month RRI. So we had specific objectives, which included scaling up sites offering cervical cancer screening. Initially, there was 25, and we were aiming at scaling up from 25 to 164. So we wanted also to ensure consistent supply of essential commodities for screening in our county, and also ensuring that we provide capacity building for our healthcare workers on cervical cancer screening and management. Next slide. So these are the things that we implemented. We started by training our healthcare workers on cervical cancer screening and management, and we did so using our national guidelines in Kenya. And then we scaled up integrated cervical cancer screening in HIV clinics across the county. Also, we were able to procure and distribute buffer supplies in terms of reagents, non-pharmaceuticals, and cryotherapy to our sites just to ensure that screening was consistently done. And then we mobilized clients on a specific day for screening, alongside screening those who came for refill. Apart from that, yes, as much as we trained the healthcare workers, because of funding, we were not able to train all in the facilities that we were supporting. So we were working with the clinicians who had already been trained to rove in facilities that didn't have the trained healthcare providers. And by doing so, they were also offering on-job training for the non-trained staffs. And we ensured that linkage mechanism was in place to take care of the suspicious lesions which were detected during screening. And of course, we also offered support supervision through the help of sub-county reproductive health coordinators and district public health nurses across 8 sub-counties, which are within Homa Bay County. So we monitored our performance during RRI period on a weekly basis, just to ensure that we were on track, and also built a system for monthly collation and reporting of our data. Next. So on data capturing and collection tools, we ensured that these were distributed in all the 164 sites that we were supporting, just to help us capture our data and check on how our performance is. So we issued cancer screening appointment cards. We issued Ministry of Health cervical cancer prevention screening forms and photocopied temporary registers to the sites that I've mentioned. Alongside that, for data collation, and this data was now collected in the tools that I'll mention on a monthly basis, was cervical cancer prevention monthly summary tool, Ministry of Health 711, and cervical cancer screening reporting tool for CDC. And lucky enough, come mid-2021, we were privileged to have Cloud EMR, and we were able now to capture our data real time on the Cloud EMR. And due to the use of Cloud EMR, we were able to get our data real time. Next slide. So on the reporting bit, after collection of the data from the facilities, using the tools that I mentioned in the previous slides, now we were capturing this data in the following sources for ease of accessibility. by even other people outside the facility staffs. So we were using the Kenya Health Information System, EGPAF Knowledge Management System, Partner Performance Progress Monitoring. And in the three that I've mentioned, this data was being captured on a monthly basis. And when it comes to that team, it was being captured semi-annually. That is specifically for the cervical cancer data. Next. So on the results, I'll talk about three results. I'll start with deliverables. At the beginning, we had only 25 healthcare workers trained on cervical cancer screening and management. But due to the intervention, we were able to increase the number by training 123 additional healthcare workers within the county. Apart from that, at the beginning, only 25 facilities were offering cervical cancer screening and management services. But again, with intervention of EGPAF, we were able to increase the number of facilities screening from 25 to all the 164 facilities that we were supporting during that period. And again, in terms of screening, we were able to screen 26,851, which was 119% against the target that we were given by the donor. Next one. So on the second results, I'll talk about the monthly trends, because remember from the start of my presentation, I said EGPAF started implementing cervical cancer screening, the integration of SEM in HIV from October, in HIV clinics from October 2020. So from the month of October to month of February, the numbers are low in terms of screening. And during this period, we had not trained the healthcare workers and even provided the commodities, because what we realized again, there was inconsistent supply of commodities for screening. So why we delayed the treatment, during this time, it was the peak of COVID-19 infection, and there was restriction on physical meetings. And remember, when it comes to cervical cancer screening and management, it is key during the trainings to offer practical sessions. So we were not able to do so during that period. So come the month of March 2021 to May 2021, we were able to start training of our healthcare workers. That is from the month of March, and it ended in May. So during this period, we were booking clients on a specific day during the days of practicals to offer practicals to our trainees so that they acquire more knowledge on now doing the services back in the facility. And that is what helped our curve to start moving upwards. And then in the month of June, remember we were through with the training as at end of May, so we were able to have the 123 healthcare workers trained, and we were able to procure and issue the commodities for cervical cancer screening and management in the 164 facilities. So due to that, we started implementing our initiative, and that began in the month of June. And as you can see on the curve, our curve is going upwards, the peak being in the month of July 2021 at 8,751. However, at August, when we were winding up with the RRI, it started dropping, and it dropped further in the month of September. This is because we were now reaching our saturation. Next slide. So on the third results, I'll talk about the entire cascade of cervical cancer screening. The first one is talking about women of reproductive age during that period, aged 25 to 49 years. We had a total of 45,148. And we were given a target of 22,351 by our donor. So remember, when it comes to targets, it is given based on the funding. So that is what the donor gave us based on the funding that we were given. And then as much as we were given that, we were able to surpass the target by screening 26,851, which was 119%. So out of those screened, 229 screened positive for cervical cancer,
Irene,
which was
can you hear me?
0.8%. And those who received treatment were 79. So reasons for suboptimal treatment, it was due to limited cryotherapy machines, we had only 7, supporting 164 facilities. And it meant clients now moving from the screening side to the treatment side. And some missed reaching the treatment side. But for the huge lesions, we were able to refer all of them. Next. Next slide.
Sorry, Irene, if you can hear me, you have 2 minutes to wrap up, please.
It's okay, it's okay. On challenges and remedials, on the cost limitation, we encouraged our clients to enroll for NHIF services, which was able to cater for some cost. And on the myths and misconception about screening, we did continuous health education to our clients on the importance of screening. And on inadequate treatment machines, there was need for procurement of more treatment machines. And we must appreciate CHAI, who were able to donate 20 thermocoagulation machines to the county. And that's really helped us to improve on treatment. And then for the trained staff turnover, we were able to offer continuous capacity building for the new staffs who came on board. Next. Next slide. So in conclusion, the Rapid Result Initiative helped us as a project to be able to surpass the target which we were given by our donor. And again, investing in healthcare workers in terms of training, it was really key, because that is what enabled us also to achieve the same, because they were empowered, they had the knowledge, and they were able now to offer the services. And again, integration of cervical cancer screening in HIV, it is possible. And we saw from the results that we moved from 25 sites, which were initially screening, to 164 sites that we were supporting. And the last one is mobilization of clients on specific day alongside screening those who came for refill really helped us a great deal, because we were able to do that as we continue with the screening of clients who just came for that refill. So that mobilization helped us to get a good number of clients to screen, and that is why we reached we even surpassed the target which we were given. Next slide. In conclusion, I must really acknowledge the following for contributing much in fighting against cervical cancer in Homa Bay County. That is County Health Management Team of Homa Bay, Facility Healthcare Workers, CDC, EGPAF Headquarters, and CHAI. Thanks a lot.
This is Oluwasanmi Akintade. I will be speaking on closing the gap for cervical cancer treatment, which is very, very important in attaining the elimination agenda for cervical cancer. Next slide. Yeah, so the Lesotho program started offering organized cervical cancer screening in 2013. Which was focused mainly on the National HIV Center. As the program progresses, we intensify treatment and with visual inspection with acetic acid. Then we train healthcare workers in all. The Lesotho program has screened over 100,000 women living with HIV and over 750 healthcare workers. The data that I'll be presenting are based primarily on women that are living with HIV. Next slide. The screening initially started at the National HIV Center. In 2016, it was scaled up to the National Hospital. And in 2018-2019 fiscal year, it was actually scaled up to 34 high volume sites, which include hospitals. Next slide. So you can see how the program was rapidly scaled up. As of the first quarter of 2019, when the program was starting, we were screening as low as 728 women in 2 quarters. However, following the recruitment and training of healthcare workers and their rapid deployment, we discovered that at the semi-annual review that follows, we were screening as high as 9,389 women within 6 months. And this was rapidly scaled up to the point that as of the fourth quarter of 2019, we were actually screening over 10,000 women, which were living with HIV in 2 quarters. And that was sustained across the program until the pandemic of COVID-19, where restrictions came in and the visits to healthcare facilities were reduced as a result of the lockdown. However, as soon as the COVID restrictions were lifted and programs returned to normal and people begin to visit the facility, you could see that in F1 quarter 3, we have as much as 10,000 women living with HIV being screened, and that has been sustained since then. So definitely this means that within this period, a lot of women living with HIV diagnosed with pre-invasive cancer, and definitely there was the need for them to be treated, and those who are diagnosed with invasive cancer have to be linked with cancer treatment. Next slide. So the treatment for precancer in Lesotho started initially with cryotherapy. However, following the release of the new guideline by WHO on thermal ablation, then definitely we transitioned from cryotherapy to thermal ablation. From the beginning of the program, we had been using loop electrosurgical excision for women who are not suitable for ablative therapy. Next slide. Okay. So screening, we scaled up rapidly, definitely in 2019-2018, and we had some challenges with regular supply of liquid nitrogen. So that definitely disrupted the treatment of women with precancer of the cervix, and it actually created a treatment gap. However, following the introduction of the thermal ablative guideline, we transitioned rapidly to thermal ablations, and we train nurses to be able to provide thermocoagulation. And also in 2020, we scale up loop electrosurgical excision procedure to all districts in Lesotho, following the training of medical doctors who are able to provide loop electrosurgical treatment. Next slide. Yeah, so as you will see in this slide, the red columns are treatment gaps which needed to be covered. The blue column, it's treatment with loop electrosurgical excision. The little orange is treatment with cryotherapy, and the green is treatment with thermal ablation. So by the end of the 2018 fiscal year, we've been having a lot of issues with regular supply of liquid nitrogen. The pharmaceutical department at the Ministry of Health reclassify liquid nitrogen as a medical gas, and that it is only hospitals in Lesotho that are permitted to procure liquid nitrogen. But unfortunately, at about that time, the Cervical Cancer Prevention Program was housed at the National AROT Center, which was a clinic. So it created difficulties in getting liquid nitrogen. So at the beginning of FY19, when the program was rapidly scaling up, a significant proportion of the women have to be treated with loop electrosurgical excision because we ran out of liquid nitrogen and we put it on places. And that definitely created significant gap for women who are waiting for treatment, which was increasing as the program was being scaled up. So by the fourth quarter of FY19, we have been able to secure some amount of thermocoagulators, then rapidly train nurses to be able to offer those treatments. We got additional thermocoagulators with time, And as we got more thermocoagulators, as we train more nurses, we are able to progressively close the treatment gap. So as you will see that the red column begin to decrease proportionally. At the beginning of 2021, we got additional thermocoagulators that almost all our high volume facilities were having their thermocoagulators. And by the second quarter of 2022, all the facilities we were supporting were actually having thermocoagulators. So at the end of quarter 4 of 2022, 178 facilities which was being supported by EGPAF was actually having their own thermocoagulator. And as of that time, we were able to completely close gaps for treatment for pre-cancer of the cervix. Next slide. Let's advance the slide. Okay. So at the end of September 2022, we've been able to cover all the gaps that were created as a result of the rapid scale-up. So out of 4,670 women who are in need of treatment, we have been able to offer treatment to 4,557, which gives us 99.7% treatment coverage for the program. 2.21% of the treatment was done by thermocoagulator at the beginning of this rapid scale-up in 2018-2019. And as you will see, 62.14% of claims were treated by thermoablation. So about 1/3 of all women with pre-cancers were treated by thermocoagulation, and 35.65%, which is about 1/4, were definitely treated with loop electrosurgical excision. So at the end of 2022, there were actually virtually only 13 women that were carried over to the following year. And by now, they will have received a treatment. So the treatment coverage was excellent for the program. Next slide. Yeah, so in addition to treatment for pre-cancer, definitely as you scale up the program, you pick up more women who are suspicious of cervical cancer. So we are able to offer them cystology following a biopsy of the cervix. And in all, we actually offer we had confirmed cases of 1,208 invasive cancer, and all of them were linked to oncology. The government of Lesotho paid for the treatment of invasive cancer. Next slide. Next slide. Yeah, so definitely in conclusion, with relevant equipment for pre-cancer treatments, highly skilled healthcare professional, which includes both doctors and nurses, and taking biopsy for histology to confirm cancer, and definitely with the availability of a cancer treatment service, it is very, very possible to close gaps, which generally follows the scale up of a screening for cervical cancer. Thank you.
Good evening. I'm Angasyege Kibona from Tanzania, and I'm supporting I'm working for USAID Afya Yangu. I want to share with the team about using the digital health innovation in cervical cancer services. And this implementation started last year in quarter 2, that's April, June. Next slide, please. So USAID Afya Yangu is implementing comprehensive client-centered health program, which is C3HP, integrating HIV and TB and family planning. We received this project for 5 years, starting 2021 to 26, and we are covering 6 regions, as you can see in the map. For the cervical cancer services, USAID Afya Yangu have 150 facilities, and also we do conduct outreach. And from these 150 facilities and outreach, you have achieved the number of clients at 7,000, which is 126% of our annual target we were given by the donor and it is the target for the women living with HIV. So the Savior is the smartphone enhanced via and services, and we started in 20 facilities in July 2022. For the fiscal year 22, we managed to screen 37,000 women, as I have said so, and the treatment rate of 85%. Next slide, please. So the Savior built on the Savior 1, which was piloted by the Ministry of Health Tanzania in collaboration with WHO and Sky Connect staff, who are the one who developed the Savior. And this Savior application helps to monitor providers' quality on visual inspection with aesthetic ACD services, and also provide the feedback immediately once the provider is actually with a woman. You can see the results and receive feedback from the reviewer. And also the Savior assists in monitoring providers' competence in decision on treatment option if they found a client is having VR positive. As you can see, we have this initiative is being supported by the WHO, the Ministry of Health, Reproductive Health, Cancer, and also we are working in hand with Sky Connect Inc. That is a private organization. Next slide, please. So this is a pictorial map showing how this intervention works. Number one, you can see that a provider using a smartphone to take a picture of the cervical image and then send the second one to the reviewer using the smartphone. So the provider and the reviewer, both of them, they have a smartphone, and you send those cervical images for reviewer to get the results. And if you see number 4 is where the results matches. If the provider says results is via positive, then the reviewer also says is positive and the results are okay. But also the provider can receive feedback that this client is having negative while the provider says is positive results. So the results are discordant. And thereafter, at the end, the results, as I said, Savior provides the quality assurance of results for the services, especially for women during their services. Next. So you can see these are the steps whenever a woman wants to be screened, and it is not for the HIV positive women only, but we are encouraging for this HIV positive because we are receiving care and treatment money. But if a client is also HIV negative, we take the photo, the image, and submit. So you can see these are the stages to undergo so that an image can reach to the review, to the saver, and then to the review, and you get results. If you see number 9, number 10, 12, 13, 14, 15, are the area where we use now the smartphone. You take 3 pictures and you send those pictures to the reviewer, and then the reviewer observe the pictures which have been sent and then provides feedback. And before taking these pictures, you need to have a consent from the woman that I'm taking these pictures to get concurrence with my fellow so that we give you a correct result. So it has been approved by the ministry, and we are using it, as I said, in 20 facilities, and now we are scaling up to more facilities. And this one also, we can see now the results from using this one. Next. So this is the app, which is in our phone, the smartphone. You log in using your smartphone. You find the home screen with a lot of area where you can get even the data at a glance. Once you pick the date, you get how many women have been screened by whom. And then this is the visual. The data which is in that smartphone is from the National Cervical Cancer Register, which is within this app. As I said, then it goes to the saver to the reviewer, and then you get results. Next. So these are the findings. Since we started, we had 340 images submitted, and 73 out of them had mismatch results. And you can see for the Q1, that is October, December, we have 681 images submitted, and 85 were mismatched. And at our right, you can see the number of images which have been submitted. Not on all 114, there are negative results. It is a mixture of information, as you can see, under the reviewer's findings. So these images, once you see, it assists a woman to get a quality services. If you find a client is having VIA positive, and then the reviewer said is negative, especially if the client is having VIA negative and the reviewer said VIA positive, a client is being called back once she has left the facility. But if she is at a facility, now a provider redo VIA and then provide the treatment according to the comments from the reviewer, or they just call, discuss each other through phone to agree the treatment to be given to the client. Next slide. So this is just a picture indicating how we started. We used Madame Zo from our far left. You see using a Madame Zo, and also find a picture using a Madame Zo on how to capture the image. And you'll find that some of the pictures of the providers in class, outside, and also they are being facilitated on how to use our right side, how to use a smartphone by a facilitator while we are in a session in one region in Tanzania known as Singida. Thank you.
Thank you so much, all presenters, Kibona, Dr. Akin, and Irene, for the excellent presentations. And we have few questions in the chat, and we've tried to respond to some of them. But just to summarize, as you have seen from Kenya, there was a rapid response initiative, which is a fast scale up of facilities through training of service providers and making sure that the supplies are available. And you were able to see the spike in terms of service delivery uptake. Again, from Akin, very impressive results in terms of high coverage on treatment of almost 100% coverage. And also even for invasive cancer, being able to provide the treatment for all invasive cancer patients. To reach there though, as you have seen in the slides, there was a lot of investment on training of service providers and making sure that the clinicians, the nurses are located in the right facilities and provide the services. And then also making sure that the treatments are also available. You are able to see that when equipments and treatments are not available, there was a bit of a drop, but you are able to see that the gaps are now is almost 0.1%, which is very amazing result with a scale up across more than 150 facilities in Lesotho. And then Tanzania, as Kibona has explained, the use of digital health solution, how it has helped in making sure that services are provided in all facilities, in spite of not having necessarily the staff members, but looking at the a smartphone. The quality assurance is also mentioned in Tanzania. So 3 very interesting and exciting results that we were able to learn from the 3 countries. So I'll leave there are some questions in the chat box, which we tried to respond, but I was wondering if we'd be able to ask if, yeah. I was able to see 2 or 3 people who raised their hands. So please feel free to unmute and ask your question so that we can hear. Yeah, please. Okay, hold on. Yes, I can see Ruth Beta. Ruth, you can unmute yourself and ask your question. Nicholas, maybe you might need to unmute them.
They have permission to unmute. I'm not sure if they have a question.
I can see a raised hand from Ruth, and they're still muted. Maybe Joshua, if you can unmute and ask your question. Okay, Polycarp, go ahead.
Yes, thank you so much, Ida, and thank you so much, the panelists. I hope I'm clear.
Yes, we can hear you.
Yes, thank you so much. So I was really impressed with the presentation, and especially the linkage to treatment, the second presentation. So I had some three clarifications that I wanted to get from the panelists who presented the second presentation. One basically is on the biopsy. Really a very good uptake in terms of the biopsy. I know, especially in our country, we struggle in terms of linkage to, in terms of linking our clients for biopsy. So I wanted to know who pays for the biopsy, how come it's a very good uptake. The second clarification is in terms of the closing in the gap to treatment. I've noted that as we were closing in the gap to treatment, the number of cases identified reduced over time across the core periods. So I don't know if there was a reduction in screening or really what caused the reduction in terms of the case identification for CS cervix. The last one is in terms of the distribution of the thermoablation across the region. Were there sites without thermoablation, and then how are you basically referring or linking these clients to treatment so that we were able now to really improve the linkage to treatment? Thank you.
Okay. So,
Thank you so much. Akin, you can hold your response. Let me give chance to others also.
okay.
Ruth, were you able to unmute yourself? All right. Temba? Go ahead, Temba. Temba, if you're speaking, we can't hear you. Joshua Albert, yeah, go ahead. Oh, Joshua Albert, you can go ahead. Joshua Albert. Okay. Maybe there's an issue in. Okay, Akin, you can go ahead and respond.
Okay, great. Thank you so much. Interestingly, in Lesotho, the government paid for treatment of invasive cancer. However, there was a challenge with diagnosis. So from the beginning of the program in Lesotho, PEPFAR had actually been paying for biopsy. And that is actually part of COP's provisions. If you look at your COP provisions very well, PEPFAR make provisions for biopsy to be taken, for cancers to be confirmed. So programs can always leverage on that. PEPFAR pays for all things, but the government pays for the actual cancer treatment. If you look at the screening coverage, if not for the time that there was a lockdown, that the period of lockdown came down, you will actually see that the distribution followed more or less like a normal distribution. So there was aggressive screening of women living with HIV that at the end of almost 2 years or 3 years, we've actually screened almost everybody, or most of the people. Yeah, so subsequently, subsequent screening were more or less follow up and re-screening. Yeah, so perhaps that may be the reason why what looked like if you look at the actual coverage initially, the actual coverage remained high. However, the peaking of precancers starts to fall down. And definitely that's a normal distribution. In your initial first screening, you peak most of these cancers. 85% of precancer are seen in women who are having first screening, followed by about 16% in women who are having repeat screening. Yeah, so most of the time in the first screening, you are able to pick as high as 85% of the lesion. Prior to the time that all facilities were having thermal ablative units, initially we had about 34 sites. And what happened is that women who are screened outside these 34 sites, they were actually referred to the closest facility among the 34 sites. For women who are having challenges with transportation, the program actually did offer them transport reimbursement. And so definitely that must have contributed in one way or the other to closing the gap. As of today, all facilities are having thermal ablative units, and all the 10 districts in Lesotho are actually having a LEAP center with doctors that have been trained. Majority of these doctors are also EGPAF doctors who have also been trained, working in collaboration or together with Ministry of Health doctors. Thank you.
Thank you so much, Akin. And as he mentioned, yes, it's funded by PEPFAR, and there's a strong support from both the government and also PEPFAR. But one of the main reasons, if I may add to Akin's comment, is the effort, the initiative was in Sankatabe Center, how that definitely made a good impression, and also extensive work has been done there, and it became a demonstrative site. And that definitely motivated and initiated and created a lot of enthusiasm within the government and also PEPFAR to scale it up further. And the scale up became very successful. And that, one success leads to another success. So thank you so much, Akin. I still see Joshua Albert raising hand. If possible, unmute and ask a question. Unfortunately, I don't know. Okay. Some of the questions in the chat are answered. I think most of them are answered. The recording will be shared by our team. I know there's a question about slides after being shared. Recording will be shared by the team here. And it's also being live streamed. So that's one. All right. Tembe, I'll give you one time. Yes, Albert, I think I see you unmuted. Now you can speak.
Okay. First of all, I'm amazed on how the team Tanzania have been tried themselves to transform the society, especially through digital life. As we know, everyone now is moving to digital using the app for this cervical cancer screening. My question is, how are you guys going to make sure the information reach to everyone, especially the women and the young girls, those ones in schools specifically? How are you going to make sure that, how are you going to spread the word and to make sure that this information reach to everyone and it's useful? Thank you. Thank you
so much, Joshua. If you don't mind, can you introduce yourself? Where you come from?
Oh, okay, sorry. I'm using this. This is Joshua's link. I'm Joshua's sister, actually. I'm using his link. My name is Angasyege. Yes, my name is Angasyege.
Perfect. Thank you. Kibona, go ahead.
Yeah, thank you for the good question. This information usually we are sharing in all entry points at facilities, even at community. So even as I said, we are reaching the community, the outreach, the far difficult to reach facilities or the community while doing our family planning, community outreach, CTC outreaches, even at facilities, we provide information that we are using the app so that to improve our quality of services. So once a client enters the room is where we provide more information. It is not widely or spoken outside, but this information of using app is being provided while the client enters the room. So in a screening room is where we provide more information, but whenever we do outreach, we promote that we are providing services according to the standards stipulated by the Tanzania government, and to provide the services which are within our quality. So we share, we provide the information. Yeah, thank you.
Thank you so much, Kibona. We can give another chance, maybe 2 minutes to ask question. And I'm checking if there's any hand, and I don't see any hand. Okay, I think I see now. Okay, go ahead, please, Katz.
Hello, my question is to Kibona for Tanzania case. I'm wondering if the mismatch in the results maybe will be attributed to the quality of the photos that are taken, or if maybe the quality of phones that they are using, is it standard to all the phones they are using, or the quality of the phone of the photos depend on the phone that an individual is using?
Go ahead, Kibona.
Thank you for the question. Yeah, the project have purchased the phone. That's why I said we are using smartphones, which is A13. We have distributed in all 20 facilities so that we have a uniformity. And the mismatch, if the reviewer reviews those images, the cervical image, they found that the picture is in poor quality. They provide the feedback to the provider that you have submitted a picture which is in poor quality. Please take a new photo and submit another image so that we can review. So the mismatch is not contributed to the type of phone, because we have given them smartphones, and we have given them the bundle, the airtime bundle, so that the internet bundle, so that they can submit this image to go to the server and being reviewed by the reviewer. And these reviewers are the competent cervical cancer trainers, who have been selected by the Ministry of Health to review the images. So there are people who are competent. Thank you.
Thank you.
Thank you so much. Okay, go ahead. I think I saw one more hand. Makondi. All right. I don't see any other hands, and we don't necessarily have to hold everybody. Okay, I don't know, just Fund. Makondi, go ahead, Makondi. Makondi, you can unmute and ask. All right, cognizant of the time, I think there might be an issue with unmuting, but as you have seen, very productive questions. Thank you so much. And as we conclude this session, I would really like to appreciate all participants who came to this webinar to participate on this meeting. And as you can see, this is a very important initiative. Saving lives of women is saving lives of children at the same time. So we really consider that children and mothers should be managed really well. And in terms of cervical cancer treatment, starting from screening and treatment, we need to scale up as quickly as possible to reach to the elimination agenda, elimination strategy. And you can see Lesotho have reached really well, covering a large proportion of the facilities with high coverage of treatment. Kenya has shown some successes in terms of early identification, and Tanzania using the digital tool. There are other countries also where EGPAF is implementing. For this presentation purpose, we have selected the 3 countries. Thank you again, the panelists, Dr. Akin, Irene, and Kibona, for the excellent presentation. Thank you. Have a good rest of the day for all the participants. We conclude our meeting now. Thank you.